So I have been with the Visiting Nurse Association of Ohio for 11 years. I'm a social worker. I started on the road seeing patients and caregivers in their homes. And that's still what drives me and motivates me, is keeping people in their homes as long as it's feasible and as long as that's the goal of the person or the family. So everything that I talk about comes from that place. It does not mean there's never a place for long-term care in a facility, but I come from the perspective and hearing from many families, I want them to be able to say, I did everything I could. Whatever that means, that's different for all people. So that's where I start. And I thought we would start today because I've heard so many times, I wish I knew. I didn't know about this. I wish I knew sooner. So I thought we would start with some really, some basics about home care. I know there are other home care providers here. And you know, I always say if you have a great nurse, if you have great staff, you've got great home care. So this information is applicable to different organizations. So skilled Medicare home care, Medicare Advantage plans must have these same requirements. So know that if you have a Medicare Advantage plan, this is not different. Some of the benefits might be different or the cost, but they have to do what Medicare does, which is provide this service. So the patient requirements are that they be homebound. Homebound does not mean cannot get out of the home. It means that they must need assistance or that it takes a taxing effort. So if someone has lung disease and they can get their walker and their oxygen and their caregiver beside them and get in the car and go to a restaurant and have a meal and come home and then must sleep the rest of the afternoon because that excursion wore them out, that still qualifies as homebound. If someone needs a walker, a wheelchair, a cane, a person, if they have such severe depression that they just don't have the energy or the drive to leave the home, if they're so anxious that leaving the home scares them, if they have dementia and maybe they can go out, but it's really scary. You know, it's that anxiety about finding your way back or remembering where you were going in the first place. So those all count as homebound. So don't get hung up on that word. Sometimes physicians get hung up on that word, but this is what it really means, taxing effort or assistance. Someone who lives in a skilled nursing facility or a long-term care facility cannot receive Medicare home care. If they live in an assisted living, independent living facility or their own home, they can. But home care, like VNA, does not go into skilled nursing facilities. We have to work under a physician. There has to be a doctor who signs our stuff, because nurses can't practice without a doctor. And it must be reasonable and necessary and part-time or intermittent care. Now what that means is Medicare does not pay for a nurse to come and live at your house. They do not pay for a nurse to come 2 hours a day, 5 days a week. They let us decide what intermittent care is, but usually it's 1 to 2 times a week. Look at that cute little nurse. So these are the disciplines that are included: skilled nursing, physical therapy, occupational therapy, speech, medical social services, and home care aides. Those are the disciplines that Medicare says agencies like the VNA have to have. We talked about non-medical reasons for being homebound, and that is even if they have no physical limitations. And that is something else different about the Visiting Nurse Association. We're licensed by Medicare as a skilled nursing agency, but we're also licensed by the Ohio Department of Mental Health and Recovery Services as a mental health agency. Most of the mental health conditions we treat are things that you are all familiar with, like depression, anxiety, and dementia. So here's some of the reasons they can go out of their home and still be homebound. They can go to church or temple. They can go to the barber or hairdresser. They can go to an anniversary party, graduation, to walk outside. Sometimes we prescribe people to take walks. They can go to any doctor's appointment, chemotherapy, things like that, or to go to adult daycare. So here's the definition, the actual definition of intermittent care. So you have to need a nurse, a therapist. It can't be something a layperson can do, but it has to be intermittent, not all the time, not 24-hour care like happens in a skilled nursing facility. So the person does have to get better with our help. The only exception to this is the mental health program. If someone stays not depressed, that's a win. And Medicare says we can continue to see that person. If someone with an extreme mental illness, like we think about schizophrenia, if they stay out of the hospital, we are allowed to continue going to see them forever. Not forever, intermittent, but for a really super long time, because it keeps them well. But if someone is having physical therapy, occupational therapy, things like that, we have to continue to work towards goals. So what's a skilled nursing service? Teaching and training, teaching someone about their diagnosis, teaching someone about their medicine, observing and obsessing, that's my job, no, assessing. Those are those typical things, but it includes psychiatric evaluation. Psychiatric evaluation is a really fancy word for we talk to people about their insides. We talk to people about their spirit and their emotional health and not just their body. And that's, our rehospitalization rate happens to be like super awesomely low at VNA. We don't send people back to the hospital a lot. And I can't do research on this because I can't withhold services from any of our patients to prove that some go back to the hospital and some don't. But I think it has a lot to do with that mental health component, because we treat the whole person and not just their body. If our medical nurse goes out and the patient can't focus on the new diabetic teaching because she can't stop crying because her kids don't visit her anymore, then we don't just keep teaching about the diabetes and the diet and the insulin or the medicine. We send in the mental health team to talk about the loneliness, the isolation, the depression and sadness, the grief. So treating the whole person is a big part about what we do. Therapy is a huge part of what we do. We want people to get stronger and better if possible. If it can be done by a layperson, it's not a skilled service. It has to be just about them. One thing that when Medicare comes and looks at our charts that they want to see is that every plan of care is different and individualized to the person. So they don't want that cookie cutter, oh, every diabetic's the same, every person with Alzheimer's is the same. Our job is to say what's going on with you and your situation, and how can we make that situation the best it can be. But these are some things that home health providers can do. Medication management is a big one. We fill lots of med planners. You know, I take like 2 pills and sometimes forget, so I can only imagine having that polypharmacy nightmare. So our nurses do a lot of that education. So here's some ideas about why home care is successful. Those first 3 weeks of coming out of a hospital, we have all kinds of data on this now, is when someone is the most vulnerable to go back to the emergency room, back to the hospital, or into a skilled nursing facility. And so we go a lot. Our patients often complain, oh my gosh, I signed up for this, and now you're sending all these people that I don't know into my house, and we're like, yes, we're sorry, but we're still going to do it because that's what keeps people out of the home. The Visiting Nurse Association of Ohio was started in 1902. in Cleveland, Ohio, by these women. That is not clip art. Those, I didn't get that off the internet. That's the actual women that started the VNA. And it was to serve people who no one else wanted to serve, largely an immigrant population in Cleveland at that time, and children. We still have that mission. We still want to take care of the people who maybe nobody else wants to take care of. So I'm really proud of that. We're not for profit. We've been around a really long time. So we've talked about these things. We talked about mental health a little bit. Again, depression. What's the incidence of depression in early stage Alzheimer's? I don't really know. I mean, it's 90-something. Almost everybody in early stage dementia has depression. Do any of us need that explained to us? No. When you realize that you're forgetting, when you realize it's not a fluke, it's not just a bad day, depression is almost always coexisting with dementia. We have home care aides too that do these kinds of things, like the agency that's providing your respite today. And we take care of people who they have a long-term chronic disease that is not going to get better, but they are not ready for hospice for whatever reason. That's our palliative care program. So let's go off PowerPoint, I'm going rogue, and talk about the Alzheimer's Special Care Program. A few years ago, about 5 years ago, one of our staff members happened to go to a conference where one of the presenters talked about the fact that Medicare pays to teach caregivers. And by pays, I mean reimburses places like the VNA. To teach caregivers. That is really super unusual for Medicare. Because if you look up, we just talked about what is home care, what is skilled home care. It will say, teach patient, teach patient, teach patient about their disease, about their medicine, about what exercises they should do, about healthy habits. Will that work with someone with dementia? You can teach it, and then you can teach it, and then you can teach it. But that's not an effective means of changing the situation and preventing emergency room, preventing rehospitalization. So it's about teach caregivers. So this staff member who went to this conference came back and we started a whole program based on just this. Because what could be more important? So our program focuses on non-medical interventions. It is done by nurses. We are a home care. But you probably know that there are no medicines approved by the FDA for the treatment of behaviors in dementia. I'm not saying it's wrong. No judgment here. But our goal is to try everything else first, because the problem with those medicines is they have side effects. Medicines like antipsychotics and anti-anxiolytics, which are like Xanax, Ativan, things like that. The problem is they make people sleepy. That's not always a problem if you're a caregiver. Sometimes that's a bonus at times. But it can make people sleepy and it can make them fall. And so that's why they're not approved. Because people who fall go to the hospital, and we've already talked about what happens then. Again, there are times when medicine is super important and necessary and the right thing to do. However, we try to implement behavior and environmental changes and teach the caregiver before implementing medicine. I wish there was a pill. Wouldn't it be awesome if there was a pill that didn't make people fall and didn't make them swing, or didn't make them shadow, or didn't make them repeat everything over and over until you feel like you want to pull your hair out? I wish there were a pill. But so far there's not. Research, advocate, woo! If we could work toward that, it would be fantastic. So what we do is go in with unrelated eyes, because I know that your relationships aren't complicated and that your families are much healthier than mine, but every family has issues, every relationship has a history, and that doesn't dissolve when someone gets dementia. That history comes with you to the current caregiving relationship. I have heard so many, no offense guys, adult sons say to their mom, "Don't worry, Mom. Don't worry, Mom. I told you I did that. Don't worry, Mom. I've got it covered." And I say, I so wish that would work. To say don't worry and it be a reality would be super, super awesome. But that's not reality. And we bring that history. I've had so many caregivers, these mostly happen to be women, who say of their loved one with Alzheimer's, "I know that he won't get into the tub because it is the one thing that would drive me crazy." I get it. I'm married too. I understand. And so it doesn't just take one time of saying, "No, he's not doing it because it makes you crazy. He's doing it because it's part of this disease. And he may have done stuff all your married life to tick you off." Just, maybe that was part of your relationship. But now that's not what this is about. Now this is about a disease process. We can't just do that one time. If you come into my family and say that to me one time, I'm going to be like, "Yeah, right." So we come back and we say it again, and we say it in a different way. And maybe we say, "How about we try this one modification this week? I'm going to be back next week, and you tell me if this one modification changed the behaviors." Because that's what we're talking about here. The Alzheimer's program is for people with behaviors with dementia. If someone is pleasant and smiling and stationary, Medicare does not want VNA to come in and bill them, because we're not fixing much right then. But we're talking about the behaviors. So we come in week after week. I worked with a retired nurse practitioner who cared for her husband for many years, and he had Alzheimer's. And she figured out, and I don't know what this says about their relationship, I'm thinking it's a good thing, if she whispered to him, "Walt, we need to get in the car now. Walt, put your foot in the car," he would do it. If she said, like, "Walt, come on, we're going to the doctor, get in the car," he was just like, "No." But she learned if she whispered, it worked. So what if we try something like that this week? What if we try taking up the dark carpet from in front of the bathtub because the person with dementia thinks that's a hole? What if we try covering up the mirrors in the bathroom this week because they think there's 4 of you in there? Because they don't recognize them and they don't recognize you in the mirror, and it's a tiny bathroom. What if we try a handheld shower this week? So it is an art. You know this. And something may work for a month, 2 months, and then stop working. Our staff's job is to help you think creatively, because it is super easy to feel like you are just backing up the car and running it into the brick wall, and backing up the car and running it into the brick wall over and over again. So our staff's job, nurses and social workers, are to say, "Hey, how about we try going around this way? How about we go over the wall? How about we dig under the wall this week?" And continue to try different things and give you somebody who's not related to you, because that's important. I love your families. They're all fabulous. Don't get me wrong. But they've got stuff, right? So somebody who doesn't have a stake in the relationship can come in from the outside and say, "What was his favorite music?" How many of you have seen I shouldn't start the sentence without remembering the name of the movie. Alive Inside. Have a lot of you seen that? Oh, it's called Alive Inside. Can we schedule that? Let's do that. let's play that. It's called Alive Inside. And it is about a project that was started at a nursing home by a social worker who brought in his iPod and stuck it in the ears of older adults with Alzheimer's who looked like they were lights on but nobody's home. And guess what happened when the music went in? Lights, lights, and sirens and flashing, yes. They have Landfair. My grandma and grandpa lived there. Where is that? Tell me the name again. Summit's Trace is doing it in Columbus. Oh, great. Sweet. Wesley Glenn is doing it also. Praise the Lord. This is fantastic. And what I love about it, I had done, before that movie came out, I had done a lot of research on modifying behaviors, and you see music recur over and over. I put a slideshow together about changing behaviors, creative care for people with dementia, it's called, and I started noticing that every slide about agitation, aggression, wandering, whatever the behavior was, music, music, music was in all the research that I saw. And the cool thing about Alive Inside, because we used to talk about classical music, like Mozart specifically or something like that. But what Alive Inside proves is that it's whatever music they loved, whatever music has meaning for them and they're passionate about. So, if you think like in 30 years, we'll be playing death metal to people with Alzheimer's. We'll have to stick around to see that. But I've seen it too. I've taken care of people in the past who cannot utter a word. And as a social worker, I'm sent to do talking. And so sometimes I resort to singing. You heard my lovely rendition of Stranger in the Night earlier. But I have a slide in another presentation saying that there's a lot of medicine in Amazing Grace. And I am not here to preach. But it's because that song has a lot of meaning. And I had a patient who literally didn't leave her bed and didn't say a word, but would sing every word of that song with me every time. She could also do the 23rd Psalm, which I had to look up. I could start. I could always start it, but I couldn't finish it. So that's what our staff does. Come in for not just for a one-time, two-time. Alzheimer's Association has funding for the one-time, two-time. Hooray! And we're working with them. If that's not enough, then we can come in too, and talk week after week and try different things week after week. One thing that we emphasize over and over is a life story and finding out what gave the person joy. Not just music, but what made them feel meaningful. There is no pill for I don't matter. There's no cure for I don't matter. Everyone needs to feel like they matter. So taking that information from their history and modifying it to the current reality is part of what we do in this Alzheimer's Special Care Program. I think you're all amazing. You inspire me every day. So have a great weekend. Hopefully the sun is still shining when we go outside.